Hello, my name is Patty Brenneman. I work for the Vermont Department of Health, the Division of Alcohol and Drug Abuse Programs. Part of my role has to do with the oversight of the Impaired Driver Rehabilitation Program, and that's what I'll be talking about today. This is more of a training for clinicians who have probably been involved with IDRP for a while. We call the Impaired Driver Rehabilitation Program IDRP for short. So let's get started. As you probably know, the IDRP is required for folks who have received an impaired driving offense and they want to have their unrestricted driver's licenses reinstated. So it's not necessarily a required program if folks do not want to drive without a restriction on their license. I like to make that distinction sometimes, but even still, it does feel like a mandatory program. So this training, like I said, is for clinicians who help folks complete their treatment requirements for IDRP. Much of the things that are listed on this slide and is reflected of your role as of the IDRP clinician are things that you would probably do in the course of treatment anyway. So for instance, administer an assessment with the IDRP participant, develop a treatment plan, determine the length of treatment that would be required or sufficient in order to determine when the person is at low risk to reoffend for another impaired driving offense. Provide and document those services as described, and inform the person and have an open conversation with any issues or concerns you have related to their risk to reoffend, and complete and obviously submit the paperwork in a timely manner to either the regional IDRP evaluator or the IDRP central office staff. More on that later. These next few slides are more of a review, so I'm going to not spend a whole lot of time on them, but just so that we are clear on what we're talking about. For people with first offenses, there is a 90-day suspension if they complete a breathalyzer and a 6-month suspension if they do not complete a breathalyzer. So folks with a first offense have to complete an evaluation with a regional IDRP clinical evaluator. They also have to complete an education component. And based on the evaluation, they may or may not have to complete treatment. And based also on the evaluation, the evaluator may or may not require an exit interview. I have some notes here on the side about treatment minimums. Currently, the treatment minimums for people with first offenses is 4 hours over 4 weeks. Those are minimums, but we'll talk more about that later. And this has changed through administrative rule process on June 22nd of 2017. So if anybody is unclear about how much treatment they are required to do, please reach out to us at central office and hopefully we can provide some clarification. For people with second offenses, their suspension time is 18 months. And it's a lot more, obviously, linear process. They are still required to do an evaluation with an IDRP regional clinical evaluator. They're still required to do an education component. They are required to complete treatment with a licensed clinician. They may or may not be required to do an exit interview with the regional evaluator. That's, again, up to them. And then after the treatment is completed, the treatment information form can be sent to either the regional clinical evaluator if an exit interview is required, or it can be sent directly to IDRP central office if an exit interview is not required. The treatment minimum hours is 20 hours over 24 weeks. So For folks with a third or subsequent impaired driving offense, they're often called people with life suspensions. It's a bit of a misnomer. The suspension is usually 3 years, but it often looks, from our perspective, the same as someone with 2 offenses. More about that in a minute, but so they are required to do an evaluation. The important distinction is that they are not required to do the school. They are required to complete treatment, and the treatment minimum hours are the same as someone with a second offense. So it's 20 hours over 24 weeks. And they may or may not be required to do an exit interview based on the IDRP evaluator. And the information, the treatment information, can either be sent to the clinical evaluator or central office for processing. More on the other DMV side of the requirements for people with life suspensions here in a minute. So there have been a few changes regarding IDRP in the past few years, so I just wanted to reiterate some of those changes. One of them has to do with the education component, or some people call it the school. So IDRP transitioned to an education component called Prime for Life in January 1st of 2019. That process is now overseen partially by the Prevention Research Institute. That company provides training for all the facilitators of that program. All the facilitators must be trained by that company before they are able to provide those educational services. It's generally a less confrontational approach than what the state of Vermont was using before. More information can be found online, but generally speaking, we talk a lot about values and what values people bring to the table, and high risk versus low risk choices instead of bad versus good choices. The curriculum itself is still 10 hours, the same that it's been for a while now. And programs have been typically offering them over an intensive format, which is 2 days, or a non-intensive format, which is 4 days over 4 weeks. So the intensive format, sometimes I would say the majority of them are offered on the weekends, and the non-intensive is usually at night during the week. But those schedules can change. So we'll talk a little bit here about the forms. The forms are all on our website, and this is the website right here. So we'll go there and we can talk more about the forms. For all folks, they will minimally have at least the release of confidential information, which can be found right here. I want to pull it up just briefly because there are a few distinctions that I like to make. If your client is a resident or has an offense in another state, then this section right here is very important so that we know what other states need to be notified. If you as the clinician would like to connect with IDRP and central office about this client in any way, please indicate that here. And another helpful section is this email address portion. It's often very helpful to be able to communicate with someone via email, but we want them to obviously authorize that communication. Oftentimes this release is garnered at the clinical evaluation. So if your client gets to receive services from you and you are not on the evaluation, we'll ask for another revised release. So I'll show you where the clinical evaluator forms. These are not forms that you as clinicians will need to fill out, but you will hopefully see them and maybe you would like to know that they exist. The first one is for folks who are required to complete treatment. It outlines the requirements based on someone's level of offense. So if they're a first offense, if they have a first offense, this is what they need to do, and this box will be checked. And folks will have to either initial and then sign the bottom. And obviously they don't have to initial all three. They will have to initial the first one, but either one of the second or third. Just acknowledging that they've been offered or they've been given a list of local counselors. So this is a form that the clinical evaluators provide to the client. So as clinicians, you will not need to complete this. The evaluation form is another form that is completed by the evaluators, but a copy of it should be provided to the client. And as clinicians, you should feel empowered to ask for it. If the client has lost it or they cannot find it, again, you can ask the client to complete another release, and the IDRP central office can send it directly to you, provided we have the release. There are many ways to receive a copy of this if the client does not have it anymore, but it is important that the client bring or is able to provide a copy to you as the clinician. So the first part has demographic information, and I'll just say that this offense information may or may not be reflected on their DMV record. So for instance, sometimes people list 3 offenses or perhaps 2 offenses, and according to the DMV and the rules in which they apply or count the number of offenses, it may not be that if they list 3 offenses that they actually have 3 offenses according to the DMV. I'll spare you from the details of how that works, but we go by what's on their DMV record. And so the second part is completed by the evaluator. It has the location, the date. The DAST and the audit are the screening tools that the state uses or endorses for the IDRP. Some evaluators use some additional screening tools, but we don't collect the information here necessarily. So offender type is, again, whether or not the person has a first offense, a second offense, or has a life suspension. So that is what you go by in terms of determining how much treatment minimums they're required to complete. And then the evaluator collects information about the last time they used either alcohol or other substances. And then there's obviously some brief free text available for the evaluator to add other information that's come up in the evaluation. There are 2 things that I want to point out that are somewhat new to this form. The first is the evaluator expectations for the IDRP clinician. This is where the evaluator would outline whether or not they think UAs and or abstinence would be useful for the client. This is mostly for a communication tool between the evaluator and you as the clinician, so that if the client is required to do an exit interview and the evaluator, for instance, has requested that or suggested that UAs be folded into the treatment process, that you have the opportunity to make that happen so there isn't any lag or miscommunication with the expectations. And so this is also the field right below it, whether or not the exit interview is required, and that will help you as a clinician determine where to send the completed treatment information form at the end. So the other form that I wanted to mention is the form that's most pertinent to the treatment clinicians. So this is the treatment information form. It hasn't really changed too much in the past few years, but I do want to just reiterate that most of the fields in this form are pertinent to complete. We need to see one of these boxes checked, whether the client has or has not shown substantial progress in treatment. We need to know the date the treatment began and ended, the number of sessions and hours. And we also need to know the diagnosis codes. And I will say that not everybody has a diagnosis necessarily, but if folks do have a diagnosis, that their treatment goals need to match that diagnosis. So for instance, if someone has an alcohol use disorder, one of the treatment goals should not be discussing their marijuana use. If the treatment goals do mention another substance, then perhaps it should be reflected in a diagnosis, or perhaps not, but it should not be reflected in a treatment goal if there's no diagnosis for that substance. I just want to also reiterate that these met and not met distinctions are important. We do need to make sure that all of them are met before we can process the paperwork. Additionally, any of the treatment goals that are not related to substance use do not need to be included. So anything related to housing or employment definitely are treatment goals generally, but they should not be reflected on this form. They do not need to be reflected. So there is also a section here to note any kind of behavioral changes that the client has made that you want to elaborate on, and some additional comments. And then it's important that the client sign and date, and then you as the clinician include your name, your license, your organization if applicable, and your contact information, and then sign and date. This evaluator signature is for obviously the evaluator if an exit interview is required. So that's it in terms of essential forms for you to know. If you have any questions, you can always connect with central office staff and we can walk through the forms. So I want to talk a little bit more about the clinical evaluation. And I know I've said some of this when I was walking through the form, but I wanted to also just reiterate that it's a screening. It's not an assessment. So the screening tools, like I said before, that we endorse are the DAST and the audit, and there's a brief interview. These screens are not long, they do not take a long time, and they may or may not involve other screening tools. So just be note of that, take note of that. Like I said, it's not a biopsychosocial assessment. And it includes, as you saw in the form, treatment recommendations, and that's the opportunity for the evaluator to include whether or not UAs and abstinence are endorsed for a specific client. And as you saw, there's a yes/no question whether or not an exit interview is required. And as I said before, the evaluation form should be provided to the client upon completion. If it's not, the central office staff or the evaluator can provide that form again, provided we have a release with you as the clinician listed on it. We can also provide it to the client again if they want to have another copy. So again, I'm going to reiterate some treatment requirements for folks with first offense. It's a minimum of 4 hours over 4 weeks. This has changed about 3 years ago. So if you're treating a client with who initiated the program more than 3 years ago, just be aware that it is a little different. But call central office if there's any question about it, and we can walk you through that. For people with 2 or more offenses, the treatment minimum is 20 hours over 24 weeks. And it's also important to note that the person's last treatment session should be no longer than 60 days from the date at which either the evaluator receives the treatment information form or the central office receives the treatment information form. So 60 days is should be enough time for you to complete the form and fax it in. We do have the authority to make some waivers around this, but we prefer it to be pretty close to the reinstatement date if they're licensed. And also, just as a reminder, these are treatment minimums. We do endorse folks to have an honest conversation with their clients about treatment expectations, how they're doing in treatment, whether or not they think that they'll meet the minimums, or if you would like to see them longer than the minimum treatment hours. So a little bit more about you all as IDRP clinicians should be doing. So we talked a lot about the evaluation form. You should review the information form on the form just to have and have another source of information to make sure that there's consistency in what's being reported. And like I said, conduct a full assessment within the initial 4 sessions. And we've said this multiple times, but the evaluation is not a full assessment. It is just a screening. You, as you usually do in your course of treatment with someone, determine the appropriate diagnoses, the treatment goals, and length of treatment. Ensure that the treatment goals are appropriate for the person and their diagnosis. I mentioned this a minute ago about how the diagnoses should match the treatment goals, and that's an important component. And also consider if UAs and or abstinence are appropriate based on the individualized clinical assessment and input from the evaluator. These should not be, UAs and abstinence should not necessarily be applied to everyone that you see for IDRP. They should really be determined on an individual basis. And as I mentioned before, if there are any treatment plan goals that are not met, the treatment form will be denied. So just be aware of that. So something that we've noticed over the years in terms of receiving many of these treatment information forms is that many of the treatment goals are not sufficient. We see a lot of treatment goals that include language such as maintain abstinence from all mood-altering substances, attend AA meetings, complete IDRP. So we'd like them to be a little bit more in the SMART format, to be specific, attainable, specific, measurable, attainable, realistic, and timely. So one of another example that we see a lot is identify triggers. So instead, maybe it could be identify 5 triggers to use substances and make a plan to cope and or reduce exposure to these triggers during the course of IDRP treatment. So it has a measurable, a timely, a specific, attainable framework around the example. I don't like to give too many examples just because I don't want them to be considered the gold standard or anything. It really should be individualized, and it should be thorough and have all the SMART components included. So I wanted to talk a little bit more about paperwork processing. I mentioned this before about how the treatment information form should be faxed to either the clinical evaluator if the exit interview is required, or the IDRP central office if the exit interview is not required. Once we get the treatment information form and everything in an ideal world, everything looks good, it takes up to 10 business days for us to process that paperwork and notify DMV of completion. DMV gives themselves also 3 to 5 business days to process on their end what they need to process. And this doesn't include if the client has other outstanding fees or fines, they will need to take that up with DMV. So I like to tell people to allow 3 weeks between completing IDRP and being reinstated. Oftentimes it is not this long, but that's the maximum amount of time that it should take. And I also like to tell clients that before they show up at any DMV that they should call beforehand so as to not be frustrated if their paperwork has not been processed yet. So we get a lot of out-of-state participants, either folks that either received a Vermont offense and are from another state, or vice versa, people who have received an offense from another state and now live in Vermont. You as clinicians do not need to be involved in figuring out how to assist that client. It's often better if the client or you, if you feel inclined, call the central office and we can walk you through the process and find out what needs to happen. There is some interstate reciprocity, but there's also been a lot of confusion about that. So I would offer up our staff to help you or the client walk through that process. Appeals is an option for many folks if they feel inclined. There's really 2 instances in which we usually see appeals. The first instance is when people with a first offense are screened and required to go to treatment. Some folks do not feel like they are appropriate for treatment, so they can appeal that decision by the IDRP evaluator. And then the second instance where we most commonly see appeals is when the treatment minimums are met and they don't feel as though they need to any more treatment. So in either case, the process is pretty straightforward. The client would need to outline in a letter or an email why they feel as though they would like to appeal, and just kind of walk through their case and reasoning why they feel that this is justified for them. And they can submit it to us at central office, either through snail mail or email or fax if that's preferred. And something that I like to just reiterate is that treatment minimums cannot be appealed. So a lot of times folks with a second offense don't feel as though they need treatment, and so they don't want to complete the 20 hours over 24 weeks. So they would like to appeal that, but since those minimums are in administrative rule, they cannot be appealed. So I wanted to talk a little bit about ignition interlock devices, also sometimes called restricted driver's licenses, RDLs. So IDRP does not oversee this program or this process. This is a DMV requirement. We do include it on the treatment requirements form. So We do mention it here if the offense occurred after July 1st of 2016 and an ignition interlock device is required. And then we have the DMV's contact information. So that is included in some of our paperwork that we provide to clients. Not all of them see that or realize that that's a requirement, but it is somewhat new. It's about 4 years old now. So even though it's required for anybody with 2 or more offenses, people with first offenses can also choose to have an ignition interlock device installed if they want to get driving right away. So there's a few things that I wanted to mention. It is, like I said, anybody can apply and receive an ignition interlock device. They will need to have completed IDRP to get it removed and not go back under suspension. So if someone gets an ignition interlock device for 18 months, does not complete IDRP and gets it removed, they will go back under suspension. So there are some barriers, and it's not to say that if folks get an ignition interlock that they will be able to, that it doesn't supplant completion of IDRP. I also wanted to mention that it's really for folks with alcohol-only related offenses. So if someone has 2 or more offenses, but their second offense is a drugged driving offense, they would not be eligible to have an ignition interlock device. That's mostly because the ignition interlock devices only test for alcohol. So those are some distinctions that we know of. Again, we are purveyors of information. We're not the keepers of the ignition interlock device process. I encourage folks to check out this website at DMV. It has a lot of information about ignition interlocks and what is expected. It is not, from what we've heard, it is not an inexpensive venture. It has an installation cost as well as a monthly cost that is often prohibitive for folks. So that's some information about that. Additionally, I wanted to mention that it's not on the slide, but if clients are recipients of REACH-UP, LIHEAP, or 3 squares, they can have the cost of the ignition interlock device reduced by 50%. So again, more information is on the DMV website, but that benefit is also for folks who are on other state entitlement programs. And the DMV can provide more information about that, but the client would need to provide a letter of enrollment and provide it to the DMV. So there have been a few changes in the past few years related to IDRP that I just wanted to reiterate. And one of them had to do with the curriculum that changed January 1st of 2019, as I mentioned earlier. And there have been a few changes in providers who are providing the IDRP services, meaning the evaluations in the schools. And the locations that have switched are Middlebury, Morrisville Stowe, St. Albans, Newport, and White River Junction. Morrisville services that were in Morrisville are not now offered in Stowe. And all of the changes, the location changes, and who's in what location is reflected on our website and with their contact information. There have also been some administrative changes with IDRP. that hopefully serve Vermonters better. We've added one additional staff person to the central office that has helped us process paperwork more timely. It has allowed us to not have a phone tree. Maybe some folks also remember that the phone lines were only open 2 hours a day. They are no longer open only 2 hours a day. They're open all day. And folks, in case they don't reach a live person, can leave a voicemail that will be returned within 24 hours or so. So we also have an email address, which is another way to get in touch with us. So that's also new that I didn't include on the slide. But like I said, processing time has been reduced. Another site-specific change is that the Burlington Intensive Program is no longer offered in Huntington. It's actually offered in Burlington. So that's been a change as well. And it's no longer a residential program, so folks don't have to stay overnight. And I guess that applies to all the intensive programs, is that there is no residential overnight component required. So if someone is local, they can go home at the end of the day and return the next morning and not have to incur hotel costs. Currently, due to the COVID pandemic, all the IDRP services, meaning the evaluations in the schools, are being offered virtually. So we don't know exactly what the future holds. So we'll see how long this virtual world will continue to occur. More information will be on our website, but the vast majority of providers and services are being held virtually. And I mentioned this before, that we can, another change is that we can communicate with clients via email if they allow us to on a release. And there's also been a new process to include IDRP clinicians on the resource list that is provided to the clients. So we have an application and have a presentation with a post-test that folks have to complete. Another change has been allowing other licensed professionals to be able to treat folks with impaired driving offenses. So through an administrative rule process, LADCs have always been able to treat folks with impaired driving offenses, but it has been opened up to licensed clinical mental health counselors, licensed psychologists, licensed social workers, licensed marriage and family therapists, etc. So that was a big change. So some of these things will be kind of reiterative, but there have been many frequently asked questions, and I'll review them shortly here. So again, the treatment minimums changed June 22nd of 2017, and that's the change is outlined on this slide. It used to be 4 hours, 6 sessions over 4 weeks. So sometimes that equated to 6 hours, depending on the clinician or the provider. But if you or the client has any questions about which treatment minimums apply, please give us a call and hopefully we can figure that out. We often get questions around THC and prescription medications. And our feeling is that the use of prescription drugs and THC should be addressed the same way as alcohol or any other drugs. Alcohol does not require a prescription, and neither does medical marijuana. Medical marijuana is not a prescription, and it should be reflected in the assessment, and the assessment should include the individual's understanding on how to responsibly use, like any other substance. And the assessment should also include a risk of harm or for reoffending and whether or not the person requires further treatment. So Again, I wanted to reiterate that UAs and abstinence are not IDRP requirements, but they can be required or suggested by the IDRP clinical evaluators or by you as the clinician. So it's also possible for the IDRP evaluators to not mention UAs or abstinence, but you as the clinician can also require them as well. So another change to the rule that might not take, that might be, won't be applicable for a little while, is that we added some language about program abandonment, which means now if the client initiates the program on or after June 1st of 2019, that they have 5 years to complete the program. If they don't complete the program in 5 years, that means that they have to start all over and pay the fees again. We were finding that many people initiate the program and have an evaluation, but then didn't follow through on the school or treatment if required. And then we found that that evaluation that they completed was really out of date and not very helpful. So 5 years we felt was enough time based on the data that we ran to have majority of folks complete the program. So I promised that I would mention life suspensions later, and now is the time. So folks with life suspensions, it's often called the total abstinence. And it's a program that is overseen by the DMV again. Like I said, they need to complete an evaluation with IDRP. They do not need to go to the education component, but they do need to complete some treatment. The treatment minimums are 20 hours over 24 weeks. But additionally, in addition to the treatment, they also need to go through a fairly extensive process with DMV. This website that I have on the slide is pretty helpful in determining what the next steps they need to take are. But in short, it involves a pretty lengthy application process where the client needs to provide letters of support. They need to provide releases to their medical information. They need to have some forms completed by their probation and parole officer, if applicable. It's a very lengthy process, but that's again overseen by the DMV. And then when the DMV receives the application, they will assign an investigator to investigate the information and the veracity of the information that's been received. So it's again required for folks with a life suspension, and they have to basically testify in front of a notary that they've had 3 years of complete abstinence from all substances. So for more information, go to the DMV and inquire with them. They are the experts on that subject. So here are the phone numbers and fax numbers for all of the IDRP locations, as well as central office. And here are our contact information. My name is Patty Brenneman. Feel free to email me or reach out to me at any point in time. If you have client-specific questions, and dare I say, if you have any programmatic questions, Lisa and Sandra are the program administrators. They, like I said, are available to answer calls all day, most days. Right now, due to the pandemic, the best way to reach us actually is via email. If you call and leave a message, we'll have to call you back, and those calls come through as either private, anonymous, or no caller ID. So feel free again to reach out via email. And again, our fax is right here on the bottom. So we hope to hear from you, and stay well.